Welcome back to NeuroClarity, the podcast that transforms complex neurology into clear clinical pearls. I am your host, Onowori Victor, and today we are doing something entirely different. Four rapid fire clinical questions, all with high yield vascular neuroanatomy and stroke mechanisms behind them. This is your crash course in recognizing patterns, imaging signs, and stroke etiologies. I must add that our cases are derived from Ching and Chen's comprehensive review of clinical neurology. That being said, let's dive in. We have question 27. Which of the following is the most likely mechanism of the stroke shown in figure 2.9? A. Cardioembolic stroke. B. Lacunar stroke. C. Embolic from large artery atherosclerosis. D. Hypotension in the setting of carotid stenosis. And E. Venous infarction. Now let's take a look at our imaging. And hola, here's our imaging. So what do we think? What do we see? Are you saying that you can see areas of restricted diffusion in a characteristic linear pattern between vascular territories? Okay, I think I was being a little bit too technical in there. First, this MRI is called a DWI. DWI means diffusion weighted imaging. In DWIs, whenever you see a bright area, it means something is happening in there. There's an area of restricted diffusion, and most likely it's a stroke. Now, do you see something bright in there in a linear fashion, as in a straight line? That's bright and it seems to stand out from this MRI. Yeah, this is a radiologic hallmark of a watershed infarction. Watershed infarctions are also known as border zone infarcts, and they occur in regions of the brain that lie at junctions between major cerebral artery territories. These regions are especially susceptible to ischemia because they're the last to receive blood flow from either contributing arteries. Let's talk a little bit about watershed infarct. Think of the brain's vascular territory like irrigation zones on a map. The watershed zones are the borderlands, which are the furthest edges of supply from each main artery. When overall perfusion pressure drops, like during systemic hypotension, these border zones become ischemic first, especially if there is already an upstream blockage like carotid artery stenosis. We have three types of watershed infarcts, and they include one, the cortical watershed infarct, also known as the external watershed infarct, two, the deep watershed infarct, also known as the internal watershed infarct, and three, the mixed watershed infarct. Let us talk a bit about this. Now, I would strongly advise that we go back to my previous video on the circle of Willis, the cows. It's very important you go through this because without a firm understanding of the circle of Willis, you may not be able to grab the concepts that we are currently explaining. So the link is below and you can always click on it. That being said, let's continue. The cortical watershed infarct occurs between anterior cerebral artery to middle cerebral artery or middle cerebral artery to posterior cerebral artery territories, especially in the frontal parietal cortex. It may present with higher cortical dysfunction, such as aphasia if it occurs in the dominant hemisphere, or neglect if it occurs in the non dominant hemisphere, or visual field deficits. Generally, whenever you do an imaging, you will see something we call a wedge shaped infarct at the cortical surface. Next is the deep watershed infarct, also known as the internal watershed infarct. This occurs between deep branches of the middle cerebral artery and the superficial cortical branches, usually in the subcortical white matter. These infarcts often affect motor fibers, especially for proximal limb muscles, leading to what's known as the man in the barrel syndrome. Man in the barrel syndrome is characterized by bilateral proximal upper and lower limb weakness with relatively preserved distal strength. So, literally, think of a man in the barrel. The third type is called the mixed watershed infarct, and this involves both cortical and deep areas. This is seen in severe or prolonged hypotension. What's the mechanism in this case? This patient's imaging shows infarct in the MCA borders, And the clinical setting includes systemic hypotension, possibly due to hypoperfusion in the context of left internal carotid artery stenosis. The carotid narrowing reduces flow to both anterior cerebral artery and middle cerebral artery territories, making the border zone between them especially vulnerable when blood pressure drops. Now, let's take a little clinical peril. Watershed strokes often present subtly at first but can progress. Always consider large vessel stenosis or cardiogenic shock or hypotension as triggers. MRI with diffusion weighted imaging is the most sensitive way to detect these infarcts. On to the next question. Question 28. A 39-year-old woman presents with Horner syndrome on the left side with vertigo, left arm ataxia, and sensory changes on the left side of her face and right side of the body. Which of the following is the most likely cause? A. Left carotid artery dissection. B. Right carotid artery dissection. C. Left vertebral artery dissection. D. Right vertebral artery dissection. And E. Right MCA stroke. What do we think? These symptoms are classic for a left lateral medullary syndrome, aka Wallenberg syndrome. Now, we've actually discussed about this in one of our cases, and I'll put the link in the description below. Horner syndrome on the left with ipsilateral facial sensory loss and ataxia plus contralateral body sensory changes. This points directly to a left vertebral artery dissection affecting lateral medullary structures. Side note, a left carotid dissection will cause Horner's but will not explain the brainstem findings. The right-sided options and MCA stroke are anatomically inconsistent. So, our answer is C, left vertebral artery dissection. On to our next question. Question number 29. A 52-year-old woman presents to the emergency department with acute onset of right hemiparesis. A CT scan is obtained and is shown in figure 2.10. Now, let us take a look at it. Which of the following is correct? A. This patient is at risk of vasospasm. B. The cause of the symptoms is lacunar stroke. C. The patient may need suboccipital cranectomy for decompression. D. The patient has hypertensive hemorrhage. E. The patient has an MCA occlusion. Let us go back to our city. What do you see? So first, I like to get myself into orientation. We are basically seeing a brain CT, patient supine, head facing up. We are at the level of the midbrain. And why midbrain? Remember, wherever you see a Mickey Mouse, you think midbrain. And there is our Mickey Mouse. Now, what stands out from this brain CT? What is so obvious? You see, I found a very great quote in the Over Story by Richard Powers. It says, "You can't see what you don't understand, but what you think you already understand, you will fail to notice." And there it is. Right over here, there is something glaring, something so subtle that if you don't know, you will never catch it. It is the hyperdense MCA sign, which is a strong predictor of large vessel occlusion. The hyperdense MCA sign refers to the appearance on CT where the middle cerebral artery appears hyperdense due to the presence of a thrombus or clot within the vessel, typically during the acute phase of a stroke. This finding is highly specific for MCA occlusion, although it's not always sensitive. If you see this sign on imaging, it should raise suspicion for a thromboembolic event like an embolism from the heart or other large artery. It is important to differentiate this from other possible causes of hyperdensity in the middle cerebral artery. And other possible causes include 1. Vascular calcification, 2. An increased hematocrit, and 3. IV contrast. Vascular calcification may appear similarly, but it lacks the clinical context of acute neurological deficits. An increase in hematocrit can cause blood to appear denser on CT scans, but is usually not associated with focal neurological deficits. When you use contrast in imaging, this may cause some temporary appearance of hyperdensity, but like we said, it is usually not associated with focal neurological deficits. So you should note this. The hyperdense MCA sign is typically found in acute ischemic strokes where thrombus occludes the MCA. It is a critical clue that directs us towards early thrombolysis or endovascular therapy as long as the window for intervention is appropriate. That being said, our answer is E. The patient has an MCA occlusion. Next question, question 30. A 59-year-old man with a history of diabetes, hypertension, and hyperlipidemia presents with a blood pressure of 60 over 30 millimeters of mercury and confusion. His creatinine kinase is very elevated with an MB fraction of 12%. His troponin levels are elevated and his electrocardiogram shows ST depression in the inferior leads. After stabilization, he is noticed to have left-sided weakness more prominent in the shoulder abductors and hip flexors. Which of the following is the most likely underlying mechanism of his weakness? A. Weakness from myopathy. B. Internal capsule lacuna infarction. C. Hypotension in the setting of a left internal carotid stenosis. D. Hypotension in the setting of a right internal carotid stenosis. And E. Cardioembolic events associated with arrhythmia. So, what do we think the answer is? Now, this patient's presentation of left sided proximal weakness, especially in the shoulder abductors and hip flexors, is most likely due to what we call a watershed infarction, which is involving the right hemisphere, specifically the border zone between the MCA and the ACA territories. Now, let's break it down. Watershed infarcts occur in brain regions between major arterial territories, and just like we said earlier on in the very first question, they occur where blood supply is weakest and are highly susceptible to ischemia. These border zones can become infarcted when blood pressure drops significantly, especially in the context of systemic hypotension. The phenomenon called person in a barrel syndrome, which we've talked about, is a classic presentation of proximal upper and lower limb weakness, while distal strength remains relatively preserved. This syndrome generally occurs when ischemia affects the cortical watershed zones of the brain, specifically areas controlling the trunk and proximal limbs. The name of this syndrome comes from the striking resemblance to a person in a barrel who can move their hands and feet but struggles to move the arm and legs from the shoulders and hip. In this case, this patient's hypotension, likely secondary to cardiac arrest, that is the myocardial infarction, combined with the presence of a right internal carotid artery stenosis, leads to reduction in blood flow in the right MCA and ACA territories. The watershed zones between these territories become ischemic when perfusion drops, which results in proximal limb weakness. This is a typical clinical pattern that is seen in watershed infarcts. Why not other answers? Myopathy tends to present with symmetrical weakness, especially of the distal muscles. This patient has very localized weakness in the proximal limbs. Lacunar strokes are typically small vessel infarctions, often causing pure motor or pure sensory deficits. Internal capsule lacunar infarction is not consistent with the proximal muscle weakness that is seen in this case. Why is it not cardioembolic event? While cardioembolic events could cause a stroke, it usually leads to a more widespread or focal neurological deficit. It will not specifically cause proximal weakness that is seen in watershed infarct. Phew, that was a long one. Are you still awake? Still conscious? Not sleeping? If yes, then let us quickly review the core lessons from today's vascular deep dive. Recap. For case 1, we talked about watershed infarcts, and we said that they occur in border zone areas between cerebral arteries. They are triggered by hypotension, especially when compounded by carotid stenosis. They can be cortical, deep, or mixed and may present with Malin-Barrel syndrome. For the second question, we talked about lateral medullary syndrome. We said that they are caused by vertebral artery dissection affecting the lateral medulla. We also said that patients present with cross findings, including ipsilateral ulnar syndrome, facial numbness, and contralateral body sensory losses. For question 3, we talked about the hyperdense MCA sign, and we said that it is a reliable CT marker for acute MCA thromboembolism. When you see the hyperdense MCA sign, think large vessel occlusion, not lacume, not hemorrhage, not vasospasm. For the fourth question, we talked about the internal watershed infarct, and we said it's caused by global hypoperfusion, particularly in patients with carotid stenosis. Look out for proximal limb weakness, shoulder and hips with preserved distal strength. On that note, we end today's session. Vascular neurology isn't just about identifying blockages, it's about recognizing patterns, understanding anatomy, and anticipating complications. From watershed infarcts to vertebral artery dissection and hyperdense MCA signs, each case tells a story. Thank you for listening to NeuroClarity. Keep reviewing, keep localizing, and as always, stay sharp. Bye for now.